Did some this? Mhm. Hi everyone. We are very excited, okay, that we are back and the ASRA Spring 21 is upon us. A lot of us has travel restriction and a lot of us cannot be with us physically in the meeting, but the science doesn't have to fade away. And we have been able to create some time slots for those of us who cannot travel, especially our trainees in regional anesthesia and acute pain medicine, to be able to come and present their work virtually for everyone. So over the next couple of days, today and tomorrow, we're going to have faculty members who's going to be joining us, and we're going to invite presenters to present their work to the entire community. And today I am joined by Dr. Raj Gupta. Raj is an associate professor of anesthesiology from Vanderbilt, Tennessee. And I am joined by Dr. Ed Mariano. Dr. Mariano is a professor of anesthesiology from Stanford University, and he is the chief of anesthesia at the VA at Palo Alto. And also I'm joined by Dr. Iman Nada, and Dr. Nada is an assistant professor of anesthesiology, and she runs the regional anesthesia service at UMass. So without further ado, I think we should just get into it, and I am going to invite our first presenter, and our first presenter is Dr. Jinsoo Kim, and he is going to be telling us about a case report that he submitted to that meeting about the pericapsular nerve block group, the Peng Block and Fascia Iliaca compartment for hip surgery in an elderly patient with hypertrophic obstructive cardiomyopathy, but they use that for surgical anesthesia. Is Dr. Kim with us, Raj?
Hello. How are you guys?
Hi, how are you?
Welcome.
Thank you.
So the floor is yours.
Thank you. It's interesting to finally meet you guys in person. I've been watching the podcast and, so I probably know you guys, but you probably have never met me. So thank you so much for inviting me. My name is Jinsoo. I'm currently a CA2 at Montefiore in the Bronx. My mentor, Dr. Muse, she'll be also joining in YouTube Live as well. We both worked on this project. This is just one of many case reports that's coming out of our institution using this Peng Block. So just a little bit of background into just very basics. Hip surgery, while it's declining as it used to be a lot more common as the common causes for hospitalization, it has declined a little bit according to some of the government data. However, as with all diseases, morbidities are increasing. Mortality is improved, and morbidity is increased. So it challenges it poses special challenges for the anesthesiologist sometimes. We have all the tools. However, how to tailor those is ultimately up to us. While at our institution, we most commonly use spinal anesthesia as a sole anesthetic with sedation for these types of hip surgeries. Other institutions, have used, fascia iliaca block from the get-go in the emergency department as a pain control, and you can also do neuraxial plus peripheral nerve block for other enhanced recovery reasons. So in this case report, we have a frail old lady, a 99-year-old lady, who has hypertrophic cardiomyopathy known. So just to be clear, she did not actually have obstructive hypertrophic cardiomyopathy at this time. So at presentation, it was not obstructive. Her LVOT gradient at rest was not very significant. However, she did have systolic anterior motion of the mitral valve, and she did have mitral regurg. And she was also 99 years old with anemia and dementia. So we kind of elected to do more of a peripheral nerve block approach because we did not want to drop the preload and afterload all of a sudden and kind of decompensate the heart as it was. And here you can see in the poster, this is the preoperative fracture x-ray, and then this is when after the surgery where they have put in the short intramedullary nail placement. The preoperative course, we gave 50 micrograms of IV fentanyl for just pre-procedural reasons. And we used ultrasound high-frequency linear probe and 3.5-inch peripheral nerve block needle, as shown in the figure 2 here. That was used for both the fascia iliaca block and the pericapsular nerve group block. So this, we also used 3 milligrams per kg dose of ropivacaine, so we limited it to 25 cc's of 0.375% ropivacaine to cover the lateral femoral cutaneous nerve, as shown on the right side of the figure 2. And we also spread the compartment to make it fascia iliaca compartment block. And while I'm not going to go over all the technical details of these blocks, I just wanted to just show you guys that we did come from the lateral part. Some sources do. I think the needle approach is more medial, but I think the most important thing about the fascia iliaca block is getting beneath the fascia iliaca and really spreading that compartment, as it's a high volume block. And we also used 10 cc's of 0.25% ropivacaine for the Peng Block, pericapsular nerve group block. And this is kind of more textbook. We did the infrainguinal approach, which is some people have done suprainguinal approaches, but we did the more conventional infrainguinal approach from the lateral side here. And I might come back to discuss a little bit of that later. So intraoperative course, she received another 50 micrograms of fentanyl just for kind of positioning her for her comfort, and we used standard ASA monitors plus radial A line, and she just received moderate sedation using dexmedetomidine infusion, 0.3 mics per kilograms per hour, and little doses of propofol, 30 milligrams total, which is more or less minimal. And she did have negative sensory tests prior to the incision to the anterior and lateral thigh. She received a total of 500 mics total of phenylephrine boluses and 10 milligrams of ephedrine to maintain her hemodynamics within baseline, MAP within 20% of baseline, and her heart rate mostly unchanged within 7% of her baseline. And surgical time total was 1 hour and 15 minutes. And in the PACU, she was monitored. She was monitored for in PACU, and she ultimately went to ICU for a 24-hour observation. And she was discharged to floor on post-op day 2 and discharged to home actually on post-op day 8. But unfortunately, 34 days after discharge, patient passed away. So I'm going to go over the discussion about.
So Jinsoo, may I interrupt you? All right.
Yes.
So you have 1 or 2 minutes left. All right.
Okay.
So yeah, because we want to allow also other people to just
Yes.
present their work as well.
Okay, got it. Thank you. So I think our case report is novel because while there have been many methods to provide anesthesia for these types of patients, for example, some institutions have used continuous spinal anesthesia actually for certain cardiac patients. We were able to use just peripheral nerve block solely, combined peripheral nerve block, and a relatively novel Peng block, pericapsular nerve block, and fascia iliaca block, which has been around for a while, to provide surgical anesthesia to the lateral thigh and for the anterior capsule of the hip for nail placement. And so historically, we've moved away from lumbar plexus blocks due to its risks and technical difficulties. I think that this is a promising start for Peng block for these types of hip surgeries in certain patients. And I think it can be just another tool in our toolbox when push comes to shove, and there is a contraindication to neuraxial, and if you want to avoid general anesthesia. I think I'm just gonna go open up to the floor for questions at this time. I'm sorry, I went over a little bit.
Yeah. No, thank you. Good work. Thank you for coming. Thank you for presenting. You're this is good. So I have a couple of questions, but I want to just give the floor first to my co-faculty. Ed, do you have any questions for Jinsoo?
Sure. No, I think that it's a complicated patient. So I think that probably one lesson that I think anyone can take away is that this is one a very good example of how you have to personalize how you care for each patient, because clearly this is a unique circumstance. It had an unfortunate end, of course, but I think that you did the right thing. You tried to come up with the best possible way to take care of this patient and give the patient the best shot, right? And so I think lots of credit go to you and your colleagues, I think, in trying to manage the patient. There's really no right peripheral nerve regional anesthetic technique for hip arthroplasty. I mean, I think that, and you probably, in preparing for the care of the patient and also some of your debriefing, probably went through some of that discussion. But my only question is, how did you come up with the combination of the Peng Block with the Fascia Iliaca?
So that was from I think the idea behind Peng Block. So practically in a lot of literature, the Fascia Iliaca block, or also known as like 3-in-1 block, historically very similar, it was purported to cover, kind of spread up cephalad and cover the obturator nerve and have more medial coverage. However, in practical settings, in a lot of literature, it doesn't cover enough of the medial side that it necessitated another block, and the block that we thought of was Fascia Iliaca block, which would spread better and have more lateral coverage. And I think that was the premise behind using these two combined blocks. And I think I'm sorry, what I meant to say was Peng Block is supposed to supplement the Fascia Iliaca block in the medial side to cover more of the obturator nerve. And I think that was our rationale.
Okay. Great. Again, thank you very much, Dr. Kim. Very nice work. And I'm gonna actually ask, my fellow colleagues here, does any one of you tend to do these surgeries under just block and sedation?
I haven't done it before.
Yeah.
I'm just wondering with Dr. Kim. So you look like you had a successful block, but what if this is like patient with dementia has moved intraoperatively, even if she's not feeling the pain? And what was your plan B for the procedure?
So that is one of the disadvantage of it's not a complete anesthetic. Obviously, spinal offers the advantage of paralysis and for the surgeons. So the backup plan could be, as I said, continuous spinal anesthesia, which has been used with intrathecal catheter. There is some literature out there that says there is that they've achieved stable hemodynamics using intrathecal catheter. Other methods are you could have deepened the sedation, or we could have offered probably LMA, a little bit of general anesthesia with advanced monitoring.
Yeah, awesome. And I see there is some ongoing discussions, but actually, I would ask, one of these guys to probably field some of these questions. Somebody was asking why you did not just use lateral femoral cutaneous with the Peng Block. And as you know, what's covered by the Fascia Iliaca is still debatable. And there are some recent literature that actually saying even the coverage for the obturator is pretty much in question right now. And if you look at the lateral femoral cutaneous itself, the fascial compartment that it lies in, it's not under the Fascia Iliaca. So yes, somebody can argue, say, like, if you really want to block the lateral cutaneous, just go ahead and block it. But I think overall, very strong work. Good job. Thank you for coming. Thank you for presenting. Please stay involved, stay engaged. And I have to ask you, what are you doing, like, in a couple of years?
Oh, so I'll be at Hopkins for my regional fellowship in 2 years.
Awesome. Very nice. So I want to see you. Congratulations. I want to see you next year, and the year after, and the year after, coming back and presenting. Okay?
Thank you very much.
Dr. Kim, thank you very much. And Dr. Gupta is going to kick you out of the screen.
Okay.
Right.
All right. Thank you. It's been
Nabil, as we're transitioning to our next speaker, I was going to say that, one of the things that I always struggle with these hip fracture patients is turning them. If we're doing different kinds of blocks, just turning them to a different position can often be difficult. And so finding procedures and blocks that you can do while maintaining the patient supine adds a lot of value potentially to what we can offer patients. And so I commend the group for trying something that may make some people uncomfortable, but may give us an avenue in those cases where maybe the quote unquote definitive regional technique is not available to you or not possible. So I think we're transitioning to Doug Arno next, I think.
Good afternoon. Nice to meet y'all.
Welcome.
Hi, Doug. How are you?
Good. Very good. Thank you for asking.
Yeah, you got me confused a little bit when you say Doug, because it says Charles and I didn't know who was.
Yes, sir. I'm one of those weird people that goes by their middle name instead. But yeah, that's just one of those things.
So, Doug, do you want to tell us about your presentation? And you're gonna have about 7 minutes to present.
Okay, perfect. So my presentation today involves a patient who was super morbidly obese with a BMI of 70.4 at the time of presentation, who was transferred to VCU Medical Center in Richmond, Virginia from an outside facility after she failed tandem and ovoid brachytherapy treatment there. The reason she failed that was at the initial facility, she aspirated at the beginning of the procedure. The physicians at that facility felt that a tertiary care medical center would be able to provide better overall care and greater level of care for her. So for those who aren't familiar with tandem and ovoid brachytherapy, I did put a picture illustrating exactly what this procedure entails. It entails 3 rods being placed, 1 intrauterine and 2 intravaginally around the cervix. And it's for treatment of local and advanced cervical cancers. Now, this patient, when she was transferred to us, she was like I said, BMI of 70.4. She had a history of diastolic heart failure. She was, or does have OSA, with nightly BiPAP oxygen requirement, GERD, atrial fibrillation, and diabetes. So for this patient, and I should say the picture at the bottom is not the patient that we had in question, but an example of someone with a similar body habitus and positioning of this procedure. The initial plan for this patient was for her to undergo a general anesthetic that would be performed at the MRI suite, where the rods, tandem and ovoid rods would be placed under MRI guidance. However, this plan had to be aborted as the patient was unfortunately too large to fit in the scanner. So with that, when that occurred, the provider who was serving as the attending of record was one of my co-authors, Dr. Bryant Tran, and was also working with one of our regional fellows, Dr. Juhi Sharma. And the decision was made that since the patient would be moved to have this done under fluoroscopy, to attempt a combined spinal epidural in order to provide long-term analgesia for this patient. Because of the nature of the treatment, she would be having to lie supine for several days while the treatments were delivered, which can be very uncomfortable. One of the reasons that was ultimately, one of the things that drove the decision also was there was a concern that if this patient was orally intubated, she may not be able to be extubated given her size and her history of OSA, which came up in discussion after the decision was made to do fluoroscopy. Given that this took place during a pandemic, the COVID-19 pandemic, and the concern for ICU beds, it also worked out to utilize a combined spinal epidural. So the patient was brought into the brachytherapy suite, and when she was there, she was sat on the side of the bed and given 8 micrograms of dexmedetomidine in order to get some anesthesiolysis. Using a 17-gauge 2E needle with a saline technique, loss was obtained at 8.5 centimeters in the L3-L4 interspace, and a catheter was threaded and left in the space with a after 3 milliliters of 0.5% bupivacaine was injected into the intrathecal space. The patient had a ropivacaine infusion intraoperatively. She had some additional sorry, I'm blanking. Additional dexmedetomidine, there it was, given during the case, and she tolerated the procedure well. She was then able to be moved to a general floor where she was rounded on for 3 days by our APS team in-house. She did on day 1 have to have her epidural rate increase from 7 milliliters per hour to 9 milliliters per hour, and she was started on a multimodal pain regimen and did receive PRN doses of oxycodone. Patient did very well and was able to have the epidural removed without complication on post-op day 2, and she was subsequently discharged home after removal of the brachytherapy device. So the main reason that we wanted to present this case is that it demonstrates the efficacy of neuraxial anesthesia in these super morbidly obese patients who would otherwise be poor candidates for general anesthesia. This is a very painful procedure that we can easily help with both operative pain and post-operative pain by utilizing the spinal and the epidural and the modalities of pain relief that they deliver. It also will help us to avoid the risks of general anesthesia in these patients who, if they have known sleep apnea and issues with carbon dioxide retention, so that we can hopefully avoid difficult extubations or potential ICU stays after these patients undergo their procedures. And this patient, like I said, did great. She, I was in the APS notes. She commented that her pain was well controlled throughout her hospital stay, and she was, like I said, able to be discharged with minimal opioid requirements during her stay. So we were very pleased to be able to present this case and demonstrate the ability of combined spinal epidural anesthesia to really help reduce not only the risks of general anesthesia, but also the risks of opioids in this patient population.
Yeah. Well, great. Thank you very much, Doug. So I'm going to ask you a question now. I don't do these cases frequently, but if you're not doing a combined spinal epidural or any form of regional modality to control the pain, normally what would you do for these patients if they are not super obese?
So in a lot of these patients, we do try to utilize neuraxial anesthesia, in order to control pain in a postoperative manner. So simply, again, because of the way that they have to stay in the positioning for an extended period of time, the device will stay in place for multiple days. It's a very uncomfortable device to be applied. So it really does help with the patient's analgesia postoperatively.
Okay, got it. Anyone has any questions? I'm going to open it to all of you guys.
Yeah, I'll jump in here. By the way, before I start asking questions, we do have an audience listening to us live. And if they have questions, feel free to put it in the comment stream. We'll take a look at them. I know we've got a couple of questions here. So feel free to engage. Even if we don't get to the question, it'll spark some conversation on the different platforms as well. We do these procedures similarly, Doug, although most of the time we do them as epidurals, as you mentioned, without the combined spinal. I wondered if with a difficult anatomy like that, did you guys talk about using ultrasound or using other radiographic information to help guide your procedure? I frequently tell my trainees that if you have an x-ray, might as well use it as part of your guidance, just to measure depth and if there's any kind of scoliosis or deviation of the spine, right, just so you know before you start entering with your needle.
So this patient, it was not utilized. and that was due to despite her body habitus, we were able to palpate the actual spinous processes to find this correct space. That being said, especially in the OB suite, here we do utilize ultrasound on some of our super morbidly obese patients in order to find the correct interspace for spinal and epidural anesthesia. It is something that we do utilize, but in this particular patient, it was not.
I think it's very impressive. I mean, I think that, again, just similar to our previous case, just how important it is to really think about each patient's circumstance and just take the best care of people that you can. And I think I like how you emphasize the use of neuraxial blocks in anesthetics, because I do think that as much as, I mean, we love the peripheral nerve blocks, we love the interfascial blocks. There's always a new one that's coming out all the time, but the role of neuraxial analgesia and anesthesia, I think, is not going away, and I think it's a perfect case for that. I also I saw the comment from Dr. Tran in the chat, which I think is amazing, and I want to point out that, I mean, he is of course a product of Stanford Regional Anesthesiology, and so yeah, his awesomeness I would like to take at least partial credit for.
I will say Dr. Tran is an excellent advisor and is a great attending here at VCU.
Yeah. So there was actually another comment in the chat. I don't know if you guys paid attention about the, thank you, Raj, about the use of, possible use of intrathecal opioids, but in a way that you really have to strike a balance, like you're not going to make the sleep apnea worse, but you're going to give the analgesia. So in your experience, or Raj, in your experience, like, do you use any of that, or? Doug, I'm going to let you, you go first.
Yeah. So I've utilized it primarily in OB analgesia. I've not really used it much in operative analgesia and epidurals or spinals. That's not to say that there's not a place for it. And I would be very interested to hear the panel's views on that as well.
So my perspective is that for most of my spinals, I've moved away from intrathecal opioids. I know a lot of people are really still enjoy them, but I find that most of the time, local anesthetic by itself does the job that I need to do. So I don't know why I'm adding something when I've already got the job complete. And so, as this case describes, if the simple local anesthetic did the job, then the only thing that you can add by adding something else is more complexity. And so I tend to go the simpler, the better. I'm not saying that it wouldn't work. I don't find that I need it in most situations. And to be honest, for when we do the brachytherapies, most of the time we just do epidurals. We rarely do the intrathecal injection because we're usually taking our time and going slow with it anyway.
Yeah. All right, I'm gonna put a shameless plug for one of the awesome panels that we're gonna have on Saturday, and it's the first panel combined between Azra and SOAP. And actually, this is exactly that very topic is one of the things that we are talking about. So we're going to be discussing the role of intrathecal opioids and how much it's visible in the OB world, but actually it's not that visible in the surgical literature. So Doug, thank you very much, and thank you for your group. And we are going to move on to our next presenter. And next we are going to have Dr. Marta Gillespie? No, it's not.
DiGiuseppe.
Yes, thank you, Marta. No. You know, when you have a complicated last name like mine, like, you know, you probably, I know the, yeah.
Yeah.
Okay,
totally
so
fine.
Marta, the floor is yours, and you're going to have about also like 7 minutes to present. Thank you very much for coming, Marta.
Okay, thank you so much for having me. It's a real privilege to present this case to such an accomplished panel, so thank you. I'm an anesthesiologist at St. Paul's Hospital in Vancouver, British Columbia, Canada. I will be sharing a description of a combined thoracic, paravertebral, and thoracodorsal nerve block technique that was successful in avoiding general anesthesia in subcutaneous ICD placement. The cardiology department at our institution has started implanting SICDs, short form for them, in young patients, essentially to avoid lead-related complications such as infection and perforation, and in patients with complex venous anatomy, such as congenital heart patients. Historically, these are done under general anesthesia, given the painful nature of the procedure. There's some lead tunneling and some dissection in the mid-axillary line, and as well as the need for defibrillation threshold testing. So unlike transvenous pacemaker or ICDs, they need to test with inducing VT and then defibrillating during the procedure. These patients have complex cardiac histories and can have significant pain after the procedure. Therefore, there has been a push at our institution to institute regional anesthesia for implantation of these devices. So in this case series, we describe 4 cases. In our first case, a 51-year-old male underwent SICD implantation for secondary prevention due to a history of VT in the setting of non-ischemic cardiomyopathy. He received 3-level paravertebral blocks at T23, 34, and 56 with 20 mils of 0.375% ropivacaine with epinephrine. During the surgical procedure, the patient received sedation with propofol and remifentanil and was comfortable until implantation of the device under the latissimus dorsi. After voicing their pain, the patient received local anesthetic by the surgeon at the pocket incision, which is under the latissimus dorsi. And then the following 3 cases, we described the addition of a thoracodorsal nerve block to complement the paravertebral blocks. As you know, the thoracodorsal nerve is a branch off the brachial plexus, and it supplies the latissimus dorsi. We used a high-frequency linear probe placed in the mid to posterior axillary line in the transverse orientation. The plane between the latissimus dorsi and serratus anterior was scanned, and the thoracodorsal artery was identified in this plane as an anatomic landmark. And you can see that in figure 1 on my poster. A needle was inserted adjacent to the artery, and nerve stimulation of the latissimus dorsi with a current of 0.4 milliamps was used to ensure appropriate placement prior to injection. And we used 5 to 10 mils of ropivacaine, 0.375%, with 1 in 400,000 epinephrine. And consistently in these 3 blocks, we found the thoracodorsal artery to be a consistent sonographic landmark for the thoracodorsal nerve. In all 3 cases, the patients were comfortable throughout the procedure, receiving moderate sedation with propofol, and in the 4th case, the anesthesiologist in the procedure room also added remifentanil. Overall, we found this technique of combined paravertebral with thoracodorsal nerve block able to provide consistent dense anesthesia, and it avoided GA in all 4 of our cases, and also deep sedation, aside for briefly at the time of defibrillation threshold testing. So at that time, patients would get a bolus of propofol, somewhere between 10 to 40 milligrams IV. And these patients are complex, as I've mentioned, from a cardiovascular perspective. 3 or 4 of them had an ejection fraction of less than 30%. They have history of ventricular tachycardia. They have structural heart disease. But also, in addition to that, they're comorbid. 2 of the patients had a BMI of over 30, and 2 patients also had obstructive sleep apnea. Thus, with these complex cardiac patients, it was appealing to avoid GA and deep sedation. And especially at our institution, where these are implanted 2 floors above the main OR, so you're in a bit of an isolated spot. So it's nice to have a safer mode of anesthesia for these complex patients. We are in the process of ethics approval for a pilot RCT to further study this technique. And in particular, we're interested in studying variables such as post-procedure recovery, quality of recovery, intraprocedural hemodynamic effects, procedural times, and comparing those to general anesthesia. That's just an overview of our technique, and I, again, appreciate you listening to my presentation.
Thank you, Martha. Strong work. I have a question for you, right? And I'm sure also, others are going to have similar questions. So we do these cases, but what you're describing as the thoracodorsal nerve block, how come that this is not you're not just calling that serratus plane block? What's really the difference between this and the serratus plane block?
So the difference is mainly in volume. First of all, we're using 5 to 10 mils of local anesthetic concentrated around the nerve, rather than a volume block in the fascial plane. as well, through the technique, we were trying to go more up cephalad or up higher to catch, making sure we catch the innervation to latissimus dorsi, which I think sometimes, and this is my first year of practice, but can be missed with a serratus anterior block, especially if you're going further down, a bit more inferior.
Yeah. I'm going to ask Raj or Iman or Ed, like, you guys do these cases in the EP on the regional?
We've just started getting requests, actually. So just about several weeks ago, and not specifically for subcutaneous, but even for more traditional device implantation, our interventional cardiologists have been getting regional anesthesiology consults for some of their patients who have not been tolerating their local infiltration for pockets and pocket revisions. So we've been doing a combination of different blocks. Actually, the more common one actually is the one that Nabil mentioned. We've been using primarily superficial serratus plane.
Yeah, that's also has been our practice. So we use serratus plane block, and the patient is, as you described, Marta, like we use propofol and Remy. And the patients usually are very comfortable. And at some point when they're doing the tunneling, and I think if I predict, this is probably what's the difference when you do the paravertebral. When they do the tunneling, we ask them to essentially put local infiltration before they do the tunneling, especially the tunnel medially, the wires that they put in. Or actually sometimes one of the surgeons is gonna, before we do the block, they come and they put marking in the skin. And just we put some local, where he's doing that. And if he needs supplement to the tunneling, we do it as well. Yeah, so it's that's very similar, very interesting. Yeah, it's great. Anybody has any question for Martha?
On your poster, I'm sure Chris had lots of things. Very creative. Yeah, so please say hi to all my friends at St. Paul's.
I will. Thank you. Yeah.
Thank you, Martha. It's actually very creative that you identified the nerve and you went and infiltrated that nerve. It's very interesting. I have some suggestions for you for planning your study after that, because this is very small case series, so you can get much information, so you can base a bigger study. I would suggest you do 3 arms, 1 paravertebral only, and 1 the thoracodorsal nerve only, and 1 the combined, and see. Maybe the first paravertebral that didn't work really well for other reasons. Maybe the thoracodorsal nerve will work by itself, and those are sick patients, and we don't have to do this invasive procedure in them. Just a suggestion.
Thank you.
Yeah, I was going to add a comment that what we've started, we haven't had a request for this specific procedure yet. We've done some blocks for traditional pacemakers and defibrillator placements. But what we have noticed is that, as Ed was hinting at, is that our cardiovascular anesthesiologists are being asked now about regional as more part of their practice. And our acute pain service and regional team often doesn't have the bandwidth to get to all of those places. Some of our ORs for cardiovascular procedures and EP procedures are quite a ways of distance from where our main operating rooms are. So we've actually started doing mini workshops internally to start training some of our cardiac anesthesiologists and cardiovascular intensivists how to do some of these fascial plane blocks as ESP blocks and serratus blocks, and just something so they can temporize people or do these little small procedures without having to have the whole team of the regional team come and cart everything over to them. So just something to think about for places that this is starting to expand, is that maybe we need to expand our reach. I know we've had long conversations about who else should be doing blocks, and does that take away from regionalists? I don't think it does. I think it expands the specialty.
Agree.
Okay, excellent.
Thank you.
Martha, thank you very much.
Thank you.
All right, so that takes us to our presenter number 4, and we have Dr. Zheyan Chen, and Dr. Zheyan is from OHSU, and he's talking about precise hemodynamic control using an intrathecal catheter in the setting of aortic stenosis for GYN surgery.
Okay, thank you guys so much. I really appreciate this opportunity to talk to you guys and present a case of this 90-year-old lady with severe aortic stenosis who presented for colpoclesis for severe vaginal vault prolapse. Intraoperatively, she was successfully managed by a carefully titrated continuous intrathecal catheter and very minimal sedation. And this technique allowed precise hemodynamic control and titration of analgesia while avoiding general anesthesia. So aortic stenosis is the most common valvular heart disease in adults over the age of 65, and the incidence is increasing in an aging population. Due to significant risk of preoperative morbidity and mortality, aortic stenosis poses a very challenging situation to the anesthesiologist intraoperatively. Managing anesthesia during surgery requires maintenance of cardiovascular stability to avoid hypotension and ischemia. Overall, I think the general culture is that general anesthesia is often preferred still over neuraxial anesthesia. And I know in a couple of hospital protocols, neuraxial anesthesia is still considered relatively contraindicated with patients with aortic stenosis. And I understand that this is a kind of a controversial topic. Theoretically, spinal or epidural anesthesia may cause a rapid and massive decline in systemic vascular resistance due to a potent sympathectomy, leading to hypotension, reduction in coronary perfusion, changes for which patients with severe aortic stenosis are unable to compensate sufficiently. However, our contention is that general anesthesia provides an even more pronounced effect on hemodynamics due to induction-triggered hypotension with a decrease in venous return. And also many induction drugs can cause direct reduction in vascular tone and also direct negative inotropic effect as well. So that brings us to our case report. This is a 90-year-old lady with past medical history significant for very severe aortic stenosis, concurrent coronary artery disease, peripheral vascular disease, and pulmonary hypertension as well. And she presented for colpoclesis for severe vaginal vault prolapse after hysterectomy. And actually there was a concern for erosion into the abdomen causing evisceration. So not an elective surgery by any means. Given her multiple cardiac comorbidities and the concern for postoperative cognitive decline after general anesthesia, we decided to go with a very carefully titrated intrathecal catheter. We did the catheter in the OR prior to the start of the surgery. And we administered preemptive vasopressors to achieve hemodynamic stability throughout the case. Intraoperatively, her MAPs were kept above 89% of baseline throughout the 3.5-hour case, 3.5-hour long case. We dosed the intrathecal catheter 1 milligram of bupivacaine at a time. And she required 9 milligrams total of intrathecal bupivacaine throughout the case. She underwent the procedure with minimal sedation. She fell asleep for most of it, except it was a long surgery and she had kind of overall aches and pains. So she ended up getting 75 micrograms of fentanyl for the duration of the case in divided doses. She also didn't require any invasive hemodynamic monitoring. We started out with a non-invasive blood pressure cuff. We cycled it every minute during the beginning of the case. And as she proved her hemodynamic stability with redosing of the intrathecal catheter, we were able to space that out to every 3 minutes. And she tolerated the surgery very well. She was phase 2 recovery as soon as she hit the PACU, and she went to the ward for recovery. And so, I think we met our anesthetic goals for this patient, which included maintenance of sinus rhythm, avoidance of pain, tachycardia, bradycardia, normal intravascular volume, avoidance of hypotension, even with the initial dosing of the catheter and subsequent doses as well. Neuraxial blockade is controversial in these patients, but I think this case illustrated that, even in a patient with severe aortic stenosis, with a very carefully dosed neuraxial technique, they don't require invasive hemodynamic monitoring, and they may only need minimal sedation to tolerate a procedure on the lower half of the body. We also continuously monitored her neurocognitive status by conversing with her as a marker of cerebral perfusion, and she remained neural intact throughout the procedure.
All right, great. Thank you very much, Dr. Chen. Iman, do you have any questions or any comment on Dr. Chen's case? You are muted. This is becoming my favorite phrase, like in any meeting, you are muted. Yeah.
So it's a very nice case. Like it's not uncommon that we face these patients, these cases, old age and aortic stenosis and severe aortic stenosis. And like this tells us how much regional anesthesia is important and how many applications we have. I have a couple of questions. What type of catheter did you use? And the other question, how long or how much of milligrams did it take you to get to a surgical anesthesia? And if you had assessed a level, what was the level then?
Right. So we used just a standard epidural catheter, but we placed it intrathecally. It felt very funny just to plunge the 17 gauge tui into the intrathecal space and get all that CSF return, but very satisfying to know that you were in the right place. We were able to start the case after 3 milligrams of intrathecal bupivacaine. And we used 9 milligrams total.
And that's when, like you felt like the anesthetic is wearing off, so you had to supplement, or?
Correct. So it was a constant conversation with her.
And you used 0.25, correct? You became 0.25? 0.25,
correct.
Correct. Did you change the position since this is a vaginal surgery? Did you make the patient anti-Trendelenburg position?
I don't think they required a lot of head downward.
Okay, nice, very nice. Yeah.
Okay, so I have a question also for Dr. Chen, and you guys also feel free to chime in. We're not putting her, we're not pinning her down with questions. So, so any thought of instead of using intrathecal catheter, you wouldn't put an epidural and just try to bring it up slowly, at least that even if you have a hemodynamic changes, it's gonna be a little bit friendlier or not as intense as the drop in blood pressure that you're gonna see with spinal.
Yeah, I completely agree with you. I think an epidural technique would be a lot gentler, and it would take a little bit longer to set up. But for most of these cases, you kind of have the luxury of time because you understand the advantages of going with a regional anesthesia and giving it time to work. In our case, because this was more gynecological surgery and not lower extremity surgery, we really wanted it to more certainty for it to work, and we wanted it to work at a higher level. So in our opinion, the intrathecal catheter is kind of the gold standard to achieving very, very good surgical anesthesia. It kind of obviates the possibility of running into issues with epidural anesthesia. For example, if there was an anatomic septation in the epidural space or anything like that, we just felt it was a little more reliable in this case.
Very nice. Raj, Ed, any comments?
I'm gonna actually pass on a great question from my friend Suba, who's joining from the UK. His question is actually about post-dural puncture headache, and so we actually use a very similar technique in which we use the epidural catheter for intrathecal use on occasion when we want to do continuous spinal. But what was the discussion about the considerations for post-dural puncture headache? Did you consider a newer micro spinal catheter? Do you have one available? I guess is a separate question. And then what was the follow-up for the patient as far as her side effects after?
Yeah, absolutely. Thank you for all the questions. I really appreciate it. Our thinking was along the same lines as yours, is that the incidence of PDPH is so low after the age of 65 that the benefits really outweigh the risks in this case. We didn't think about using a microcatheter. I'm gonna have to look more into that. That's an interesting suggestion. And then in terms of
Ed and the panel, do we even have microcatheters here in the States? I mean, I have, at least in our place, like, we don't see them. I don't know if you guys see them.
We don't have them in stock, but I believe that they are approved again.
They are available. Yeah, I honestly, I have not seen them. But that's fine. Yeah.
Is it? From my recollection, is that the same type of catheter that fell out of favor because it delivered such concentrated high dose local anesthetics?
That's the one.
Yeah, why? And it's the reason why people stopped doing intrathecal catheters. So I'm curious to know why it's coming back and what's different now compared to. I don't know if it's a multi-pore now instead of I think it was a single pore catheter originally. I don't know if they're multi-pore now, and that somehow reduces the risk. Not sure. So, Dr. Chen, are you a resident or you're a faculty?
I am a regional anesthesia fellow at OHSU.
Oh, very nice. Excellent. Very good. So thank you very much for being involved and being engaged, and thank you for coming out and presenting your work. Thank you.
Thank you all so much. It's been an honor.
All right.
Thank you.
Thank you.
Thank you.
Do you want to take the next one?
Yeah, I'm going to. We're just getting the screen switched up here. And I don't know if Dr.
Is Kevin here? Isn't that in the panel?
There he is. There we go. Is it, Kevin, is it Bonilla? Is it Bonilla or Bonilla? Bonilla. Okay, so I said it right the first time. Yeah, I'm taking over introduction duties because we don't want Dr. Elkassabany to give you an artificially elevated introduction because he's on the poster as well. So he absolved himself from the introduction. And the introduction is going to be brief. Kevin's going to be presenting his poster on optimizing postoperative pain control in ambulatory hand surgery using acetaminophen with codeine versus acetaminophen. And I think it's getting covered up here, but acetaminophen with ibuprofen. It's a double-blind randomized controlled trial that you guys did. So, Kevin, I'm going to let you take it over here.
All right. Thank you very much. So I'm an anesthesia resident at Penn, and we were able to do this study in conjunction with our orthopedic department here, which I think is good because on our regional service, we often help co-manage some of their pain issues with their patients. So this project, obviously, we all know that we are, have an ongoing opioid epidemic, and as such, prescribing practices continuously need to be reevaluated so that we can limit our use of opioids to where it's appropriate. And patients who are undergoing minor hand surgery are overprescribed opioids, which obviously can lead to overuse, abuse, or diversion. And in our institution, originally, minor hand surgeries were prescribed Tylenol with codeine as our kind of frontline treatment for postoperative pain. And if patients had a contraindication to that, they were given oxycodone or oxycodone with acetaminophen. The majority of these ambulatory hand surgeries are comprised of trigger finger or carpal tunnel releases. And so we chose to look at this grouping of procedures and compare the efficacy of a combination of acetaminophen and NSAIDs, specifically ibuprofen, to an opioid-based regimen for postoperative pain control. And our hypothesis was that a non-opioid postoperative regimen would be equally effective and potentially have fewer side effects without impacting patient satisfaction as compared to an opioid-containing regimen. And so this study was a double-blind randomized control trial. We grouped patients into two treatment groups. The first one was 650 milligrams of acetaminophen with 400 milligrams of ibuprofen. And then the second group, our opioid treatment group, was 300 milligrams of acetaminophen and 30 milligrams of codeine. We enrolled patients over a period of 2 years from about 2016 to 2018. And then patients were asked to complete a pain diary each day for that first postoperative week. And the endpoints that we looked at, which were covered by this pain diary, they were asked to complete a visual analog scale pain score assessment every time they took one of their pills. They were called and asked to complete a quality of recovery questionnaire. And then at the first postoperative visit, which was about a week after their surgery, they returned with that diary and with whatever pills they had left over. And so the number of pills that they used was recorded. And then they were also asked to complete side effects anytime they took a dose of pain medication, so that we can kind of assess all of those things. Our primary endpoint being that pain score. And so the overall flow of the study, patients were enrolled for surgery in clinic. If they met criteria, they were consented either there or on the day of surgery. They were randomized. The randomization was handled by pharmacy, so everybody was blinded, and the pills were in a uniform container so that there was no way to tell the difference between them. Somebody administered the questionnaire, quality of recovery questionnaire on post-op day 2 over the phone, and reminded the patients to bring their completed pain diary. And then, as I said, about a week after the surgery, they returned that diary with any unused medications. Overall, we were able to screen 429 patients. We excluded 289. We had pretty strict exclusion criteria. So really any kind of medical history, honestly, anything that made them above an ASA 3, if they had a history of using opioids or opioid abuse, any sort of allergies, and some of the most common things were just a desire for a preference for having opioids as part of their treatment, or a preference for not having opioids as part of their treatment. So ultimately, we randomized 140 patients, 70 in each group. As we can see in the diagram, some patients withdrew due to uncontrolled pain, or chose not to participate after they had their surgery, decided that they wanted one option or the other. And then ultimately we ended up in 64 patients in the opioid containing group and 66 patients in the non-opioid group. Looking at our endpoints, the graph on the side there shows our pain scores over the first week between the two groups, the opioid group and the non-opioid group. And we can see that there's no significant difference between the two groups as far as how the pain scores change over the course of the week. As far as our secondary endpoints, again, there was no significant differences in the quality of recovery scores that patients reported, the number of pills that they consumed, or any instances of patients complaining of poorly controlled pain and desiring to withdraw from the study or receive additional medication. And then as far as differences in side effects between the two groups, looking at the total week or initial week, initially the only significant difference was in drowsiness, which actually ended up in the non-opioid group. And then we kind of did a subgroup analysis looking at only data after the first 48 hours to try and eliminate the effects of any of the sedation that they received for their procedure. And at that time, that drowsiness difference kind of fell away. And the only significant difference that was noticed was constipation being greater in the opioid group. And then I should say all of these patients only received sedation or pure local for their anesthetic. You know, if they had a nerve block or general anesthesia, they were also excluded from the study. And so, you know, what we showed was that we did, you know, as far as our standard prescription that we started when we began the study versus the non-opioid containing group, there was really no difference in patient outcomes, and that we could safely and without affecting patient satisfaction move towards a non-opioid treatment regimen for these patients postoperatively. And we also noticed some interesting things, mainly the main reason that patients, one of the most common reasons for patients to not want to enroll was they're already the preferences that they had for receiving or not receiving opioids, showing how education preoperatively can really affect what patients want, and hopefully, decreasing their opioid requirements. The study was limited by our strict exclusion criteria. Obviously, we looked at a very specific subset of patients, but we were able at our institution to change the baseline prescribing practices. And so now the order set for these procedures afterwards, baseline just includes acetaminophen with an NSAID. And that's for our go-to treatment as opposed to an opioid-containing regimen.
Thank you, Dr. Bonilla. I'm going to save the really hard questions for Dr. Elkassabany to give you at the end, because that's his job. I'm going to make a quick comment, and then I'm going to pass it on to Ed for a question. It's interesting to me that our culture is such that when we include an NSAID in a study, we feel obligated to exclude all of these reasons not to give ibuprofen and acetaminophen, two drugs which I can go to any grocery store or pharmacy or anywhere basically in anybody's house and go grab some and give myself a much higher dose than any of these, and people routinely do. It's a commentary on where our culture is, sort of the anti-NSAID culture that we've fallen ourselves into. But Ed, you have a comment or a question about this study?
Yeah, I thought this was great. I mean, I think that it's so important, I think, that we look at just finding data to guide some of our opioid prescribing practices, because I think that clearly regulation, legislation have already rolled into place without a lot of evidence. So I think this is great that you're doing this. I had a couple of design questions. One was, I'm assuming from the numbers that you included and randomized that this was actually a true equivalence study, that you actually had planned in advance, that you were going to be looking for significant overlap. Is that correct?
Yes, that we were going to have. Yeah.
Do you know how you designed that? So what did you consider your what would be a clinically relevant difference in the pain score, and how did you set your confidence intervals for the equivalence study?
I think initially when we were looking at this study, we decided, we ultimately used a difference of 5 millimeters on the visual analog scale, because
is that on the 100?
That's
on the 100 millimeter.
Honestly,
no, Ed. I think it was in the 1 to 10.
It's.
It was. No, I'm confused. Yeah.
Some people use either a 0 to 10 or 0 to 100, and so I was just curious to
I think
either
it was
10
0 to 10
centimeters or 100 millimeters.
Kevin, correct? Am I correct? 0 to 10.
I think so. Yeah.
Because it's reported here, the VA scores on the chart imply the 0 to 10 score.
Yeah.
On the so I'm imagining that's probably what you guys designed.
Yeah.
So I think that there always not to get you stuck on it, but I think it's important. I think when you're trying to figure out equivalence, that equivalence basically means that you still set it a priori, similar to the way you'd design a superiority study. But in this case, you're actually trying to figure out, well, what would you consider not clinically relevant? And if, let's say that your difference in pain scores in 0 to 10 is let's say 1 or 1.5, and you have significant overlap of those populations, then you've already decided ahead of time that those would be equivalent. And so it's the only way that you can say at the conclusion of your study that these are equivalent, and rather than just saying that one is not better than the other. Sometimes we read this still in articles where people design their studies on superiority, but they don't actually design it statistically to show equivalence. But sometimes, like, you'll see a one-liner, like in the abstract conclusion, saying that these groups are the same. And so I think it sounds like you guys designed it really for equivalence, which I think is the right thing. The second question I had was about the dosing. So why was there a difference in acetaminophen dose in your two groups?
Because I think our second treatment group was mimicking like if we had given the patient Tylenol number 3, and I think that's that's what they would have received in the commercial Tylenol 3 that we would have given them. So yeah, the acetaminophen doses are not equivalent between the two groups.
Thank you.
Yeah, I guess the question is it teasing out just the effect of the NSAID or the combination of the acetaminophen NSAID, and you guys are testing for the combination as opposed to the acetaminophen codeine combination. So there could be a future study that teases out which of the ones made the bigger difference, the higher dose of the acetaminophen or the addition of the NSAID to the mix. Iman, do you have any questions or comments about this study?
No, actually, I like this study because, like, I feel it adds to our efforts to avoid unnecessary opioid prescriptions. And these surgeries, like trigger fingers, and these surgeries are not that painful and can pass without opioids. And this is the evidence here.
Nabil, you want to take Kareem's question here that I just put up on the board? He said, what was used for breakthrough pain? I imagine this is the breakthrough pain medication.
Yeah, I honestly, Kevin, do you remember, like, what was in the design for that?
When you say breakthrough pain, you mean if patients had the whatever the study drug and then did not, and then had excessive pain and say called the office and asked for more? I think at those point the patients received oxycodone and then were excluded from the study, because that was the next. That was kind of the escalation.
Yeah, how many did we have escalated and exited out from the study?
7 people after randomization were withdrawn because they called the office and asked, for additional pain medication.
And do you have the distribution of which groups do you belong to?
5 patients were in the acetaminophen with codeine group, and then 2 patients were in the acetaminophen with ibuprofen group.
Yeah, that's even like more interesting. Yeah.
Yeah, and per Kareem's question, I would probably include those people in the reporting. I wouldn't exclude them. I mean, it seems like that's data that's at least an intent to treat analysis on those patients, because that's an important variable to consider, is how many of those patients, and to find that it was the codeine group that actually fell apart more may be quite telling.
Yeah.
Nabil, sorry.
So, no, I have a question for you guys. Like, is the use of the Tylenol number 3 as a trade name, is that really in the surgical, the surgeons that you deal with, is that really fallen out of favor and it's becoming almost like, not a fashionable prescription anymore?
Yeah, I would say that in general, I think codeine is not commonly used in our practice at all. I mean, I think that, well, part of the reason why is that I think that there are lots of reasons to avoid prodrugs in general, right? So I think there are always going to be, some patients will be responders because they metabolize. Some people will be partial metabolizers. Some people will be non-metabolizers. And so, which is why there's so much variability in drugs like codeine, hydrocodone, and tramadol. So I think for those reasons, I think that they are complex, and so I think that the design. I mean, clearly, I think for one, I want to give you a lot of credit. I mean, doing these kinds of collaborative projects, especially with outside our specialty, I think it only strengthens your relationships with your surgeons to practice clinically and do scholarship together. And I think that's great. And I think that there are always a lot of complexities. And so I've been on the other end of trying to answer design questions about a study that I partially was involved in designing. And so I totally get that. But yeah, I think that these are the kinds of questions I think that will probably come up in the review process. So I think it's good to know in advance what you're getting into. And if you can, then clearly in the manuscript drafting, if it hasn't been submitted yet, then you can acknowledge some of these limitations, or even preface your manuscript writing so that way you accommodate some of the explanations that you've given us already.
Yeah, it's interesting, and I think this is something that we talk about, and you and I had talked about this before. The prescriptions for opioids or even non-opioids medication, it's almost like culture-driven, in a lot of institutions, and in the surgeons' minds, it's like an escalation protocol. like you talk about tramadol, and then you talk about Tylenol number 3, and when they really discuss them, they discuss them as if like they are kind of not really opioids. They are kind of the opioids, but wink wink, not really, right? So it's always like interesting, like the thought process, and the more you collaborate, I agree with you 100%. The more you collaborate with people from outside your institution, like really like that you get a flavor or a taste of how the practice is. Yeah.
I want to comment.
Kevin, great job. Thank you.
So I was going to make one last comment. Was Kevin, you made a quick passing comment at the end of your poster, which is that you changed their order set to include this as the default option. I think that we have to be recognized that a lot of times when you operationalize studies like this and do it in collaborative ways, most of us, and I don't want to pick on surgeons because I think we do it in anesthesia as well, we're looking for good enough. We're looking for data that's good enough to change our practice. And then the second part of it is we're looking for the easiest path. So if you make it easier to order this versus ordering the Tylenol number 3, guess what? People are going to order this once they get in their head that it's good enough, right? And so it's those two components, is that you have to establish some sort of efficacy, even if it's not even an exact equivalent, even just close by, will often be enough of a trigger, and then you make it easy enough, and then people start changing their habits. I think getting to the point, why did Tylenol with codeine get used at all? Well, it was easier to prescribe one thing. Why is Percocet, Vicodin, all these combo drugs, why do they do so well? They were easy to order than asking somebody to take 2 or 3 different medications. Why did people order for 30 days? Because it was easier to order 30 days than it was to order for 3 days and then have to have a patient call you back and try to get another order in. So we have to recognize when we operationalize a lot of this literature, how do we make good enough and easy enough part of the execution?
Great points, Raj. Yep.
Yeah. Nabil, you want to wrap it up? Really, thank you very much for all our presenters today. Great case reports, great presentations, most first and foremost, thank you all for coming, especially our trainees, who came in and they put themselves out there, online for the presentation. Thank you very much. And really, this is an effort that was spearheaded by this group and from the ASRA leadership to try to give a platform to those who did not have the chance to come and join us in person, to come and just present their science and present their work. Thank you very much. And don't forget, tomorrow, come and join us at 6:30 p.m. We have another group of abstracts. Actually, we have 8 abstracts this time. So come and join us and just learn what other people are talking about. To our faculty panel, Dr. Gupta, Dr. Mariano, Dr. Nada, thank you very much. I really appreciate you coming in. And I'm going to see you 1, 2, 3, all of you in Orlando in about a couple of days.
Sure. Yeah.
Looking forward to it. And hey, 6:30 Eastern. So I messed that up on my calendar first. It's 6:30 p.m. Eastern tomorrow. So just make sure you get the time zone correct for yourself.
Great.
I want to thank all the participants who joined in from abroad. And we had some great UK participation out there. So thank you all.
And I see, and Mary also is cheerleading on the side.
Yes.
Great. Thank you.
She's always taking care of her trainees out there. So
exactly. All right. Thank you guys. Have a good night.
Bye, everybody. See you tomorrow.
Thank you.